Well, welcome to GW Integrative Medicine, the podcast about disease prevention and health promotion from the Office of Integrative Medicine and Health at the George Washington University School of Medicine and Health Sciences.
I'm your co-host, Dr. Misha Kogan, Chief Medical Officer at GW Center for Integrative Medicine and Associate Professor of Medicine here at GW.
And I'm your co host, Janet Rodriguez, the office's administrative director. Today, we're discussing ketamine and mental health with integrative psychiatrist Scott Shannon, MD, one of the world's leading experts on the therapeutic use of psychedelics in psychotherapy.
In 2010, Scott founded the Wholeness Center, the largest integrative mental health center in the US. In 2019, he helped to launch the Psychedelic Research and Training Institute, or PRATI. This visionary institute provides a platform to train professionals in ketamine-assisted psychotherapy, do research, and provide a deep connection to self and nature.
Scott has published 4 books on holistic and integrative mental health, including the first textbook for the field in 2001. And he's also published numerous articles on cannabinoids in mental health.
Scott and I go back quite a while ago. We were working together at the American Board of Integrative Medicine, and I think actually, Scott, you're one of few people that I can say you saw my growing from a medical student when I was involved in AMSA, and we're talking 25 years ago, all the way to now being a colleague and working on some projects together. So it's such a pleasure to have you here and to give us this time to be able to sit down and talk to us. So welcome to GW Integrative Medicine, Scott.
Thank you, Misha and Janet. Oh, real happy to be here. And it's just, such a wonderful journey as we've gone down this path of integrative medicine together and to see things blossoming for all of us. So really happy to be here.
So, Scott, you've been one of my main mentors on this topic, and our center started using ketamine when we had a psychiatrist back almost 10 years ago. And I remember I first he wanted to do it, and I said, well, I know just the right person that I can learn from too. So, for us, it's been a topic of some history, but I think we thought of talking because you've also had some really interesting novel directions of using ketamine for burnout and healthcare practitioners. So we'll talk about that. But maybe let's talk about this since you've been doing this work clinically for so long. Let's just do a little bit of basics. I mean, what is ketamine? Why is there such a popularity of it? And how are you seeing it being so effective in a mental health space?
I think ketamine is a transitional agent between conventional mental health care and fully integrative mental health care or psychedelic medicine, because psychedelic medicine really takes the basic principles of integrative mental health and moves them in a very powerful and useful direction. I worked in integrative mental health for quite a few decades and felt like we did the body and the mind well,
Mm-hmm.
but the spirit, we really sort of fell down and we had very inefficient, ineffective tools that weren't readily and reliably applied. And I think what ketamine brought us is a tool that begins to introduce us more deeply to spiritual medicine and the realms of psychedelic medicine, which have those two terms have huge overlap. I think that psychedelic medicine is its core is a way to engender interest, support, engagement in spiritual medicine for the people we work with often. And I think that ketamine just has such enormous potential as this transitional agent because it's easy to use, it's safe, it doesn't have interactions with other psychiatric meds, which so many of the psychedelics do. It's short acting. It's more predictable than the psychedelics.
Mm-hmm.
And it, because of the route of administration can be varied, it it can be used as a tool in so many different ways. And we're now beginning to realize, I think, as we were talking earlier, that neurodegenerative processes and neuroinflammatory processes that
Mm-hmm.
we just don't have great tools for. And this is such a powerful tool that works in such a broad manner. And the healthcare systems know this medicine. It's found in every hospital. It's a World Health Organization essential medicine. And doctors understand and know and trust ketamine. So it's just a lovely tool.
Hmm. It's amazing you straight up front brought the word spirituality. I mean, I have not heard any other expert on this topic dropping right in there, like on the first sentence, basically. I tend to hear this word come up, of course, in conversation, but not as a first thing. People would often start talking about this being an antidepressant, talk about some of the neuroregenerative aspects, but I really resonate with what you said. I mean, I think it is a kind of a highway into personal spiritual domains for our patients in a society that grossly underutilizes the resource of spirituality as a healing modality. And suddenly the highway is wide open, and so many people want to take this route. And it's also opens up an important point because you know massive, quick spiritual shifts do need to be guided, and they need to be guided carefully, right? And there's a sort of you know, maybe some risk of people doing ketamine in mass. I don't want to go back to what happened in 70s and 80s, but if you do things unguided, you're risking certain things. But the fact that there's a profound interest in this topic, what are you making of it? I mean, it almost sounds like entire society is running towards spiritual awakening at this times, and this is a tool. I think it's good, but I mean,
My view is that since Galileo, 400 years ago, we've gone down this path of materialistic science, which eliminates self, which eliminates psyche, which eliminates spirit from our knowledge base and from what we consider as important and valid. And I think the end result is we have a materialistic society that's consumer based and is kind of empty and void. And I think what's happened now, I call the last 400 years the outward arc. We have cell phones, but did we trade our soul for a cell phone? And I think we're at this moment, the cultural moment with psychedelics and ketamine being exemplar of that, is that we're really turning and moving on an inward arc where we're starting to value psyche, spirit, purpose, meaning, all these elements that have been missing from our knowledge base and what we consider important. And I think ketamine is just a transitional tool that reflects that interest and that desire to go inward and to go deep.
mhm, mhm. So, you know, maybe that's why any significant chronic illness where patient is struggling with finding the path to healing, ketamine has potential. I mean, we've seen it being effective not only in the mental health domain, but in pretty much anything really severely chronic. Like, we just before we started, you and I got on a little bit earlier and we talked about long COVID a little bit. We talked about even neurodegenerative conditions. I mean, literally Alzheimer's disease. So there could be a potential here in so many broad directions simply because rewiring of the psyche can have that profound transitional effect. What have you observed clinically that really makes you an awe? Like, I mean, I don't want to put words in your mouth, but I presume it's going to, since you're a psychiatrist, it's going to be a lot of mental health issues. But what are you finding ketamine being is especially good for?
I think ketamine is especially good for people that are stuck. And I think that's one of the most common reasons that people come to see a psychiatrist.
Mhm,
It's not specifically, I have treatment resistant depression or I have anxiety, I have PTSD. They're stuck in a place that does not feel helpful, positive, connected with life, connected with joy and a deeper satisfaction. And what I see is that ketamine is a tool to go in and help people get unstuck. I think it's different than the psychedelics. There's different power. There's challenges with durability, which I think is the weak side with ketamine. And when we started working with ketamine 10 years ago, we were doing IV ketamine only. And we found that people just relapsed in 6, 8, 12 weeks. They were back depressed again, much in the same way. And we realized that our treatment episode with ketamine was really a moment of opportunity to help them to make some shifts. There's this window of neuroplasticity, there's this energy, there's this engagement, there's this excitement that they've been missing in their life. And we can use that period to help them make lifestyle changes, attitudinal changes, deeper changes in their practice, their relationships, and help them get connected with their deeper self. And that I see sustaining people.
Scott, I am sort of at a disadvantage. Excuse me, y'all. I'm getting over COVID. I'm at a disadvantage because I haven't known you the way that Misha has. So that's why I need to ask you the question of what led you on this journey? Because you've been doing this since you were in graduate school.
Yeah, well, certainly formally, after graduation from medical school and my internship. So that's a great question, Janet. I got connected with Andrew Weil in the early 70s. I was a student at the University of Arizona. He was just arrived junior faculty at the medical school. I was wanting to do research and my thesis on consciousness. And my psychology professors, number one, thought I was crazy. And number two, had no interest in this topic because they were running rats in mazes. That was the thing at that point. And they said, well, you should probably go work with this guy out in the desert. I think he might have some interest in what you're doing. And
Oh,
connected
oh,
with
oh, sorry to interrupt. All roads lead to Andy.
Andy.
True.
And what's interesting is Andy's had these joint interests in psychedelics, altered states, and integrative medicine and healing. And these things have woven for him like a double helix through his career and for me as well. And certainly my time with him just deepened my interest. I was a naive Catholic boy out of a Jesuit school, had never really heard of psychedelics. Um, and I got to the University of Arizona and it was sort of drinking from a fire hose from Andy about altered states and psychedelics and MDMA and things that I just never encountered. And I just so happened to arrive at a fraternity where my fraternity brothers were very experienced psychonauts, explorers of the deeper psyche, and were very, very comfortable with psychedelics. And they brought me along. So I said I got the lecture from Andy in the lab from my fraternity mates. Um, so that just deepened my process, helped me in sort of writing my thesis, and just lit this fire about that these things seem so deeply and closely connected around healing that I've just been intrigued how we heal ourselves, how the mind heals us, how the spirit heals us, and these medicines are a tool to touch those spaces.
So let me ask you a tough question. Before we talk about, what you do now. Ketamine is a drug, right? It doesn't come from nature. I mean, if we look at all the other psychedelics, um, there's they're all divided into two categories, right? So you have this natural plant extracts or actual plants, like in case of mushrooms, you can consume entire mushroom in dried form or whatever, and you'll get an effect. But ketamine, LSD, MDMA, they're drugs, so they're synthetic. And
Mhm.
yet they're still, in the grand scheme of thing, feel like they're the substances that completely open our consciousness. We're in an integrative medicine, we don't like using drugs, right? So my point here goes like this. How come? Like, how come do you think in this evolutionary path we're given the substances which are clearly, chemicals and they haven't been with our evolution for all that long. They've relatively recently, if you compare them to mushrooms or ayahuasca, I mean, some of this modality has been used for probably thousands of years, not even hundreds. What are you making of this separate? What are you making of this? There's just multiple medications, ketamine included, that are given to humans as the consciousness opening drugs, but they're synthetic.
I tend not to see such a huge difference between natural agents and synthetic agents. I think what I look at is how are we applying these things and what is the end result of what they do?
Hmm.
For example, I think we can look at natural agents that people can get into very destructive relationships with, alcohol, tobacco being, I think, really good examples. And one of the things that I learned from my mentor, Andy Weil, was that it's not so much about the agent, it's about the relationship. And is the relationship ritual based? Is the relationship sustaining? Is the relationship respectful? Is the relationship bringing about positive change and evolution? Or is it destructive and keeping people stuck? So I think whether we're looking at natural agents and whether we're looking at, whether we're looking at ibogaine or DMT, or whether we're looking at MDMA and ketamine, it's about what type of process does this engender? What is the end result? What is the relationship that can be maintained? And I think we have to look at toxicity and risk and all these things. But as we move into the model of psychedelic medicine and out of the model of conventional medicine, in conventional psychiatry, we're managing misery. That's the best we do. We're giving agents that people take every day, often extremely toxic agents. I would say that, to my view, olanzapine or Zyprexa that we use in psychiatry, millions of prescriptions written every day, billions of dollars in sales, is more toxic than any of the synthetic agents that we use.
Hmm.
Because if you look at it on a dose per dose basis, what is the risk? What are the side effects? I mean, a third of the people that get put on olanzapine gain 25 pounds and have, risk of type 2 diabetes within a month or two. And is that really something that we should be doing? And yet we do it. So I think we need to just step back and look at what is the cumulative risk, what is the allostatic load that we're putting on the body and the homeostatic mechanism of balancing and finding health. And I think if we're looking at 3 MDMA trips that people would have experiences like we had in our phase 3 trials with MDMA versus a lifetime of olanzapine, I mean, these are logarithmically different risks.
And they're not comparable, the risks. The risks are just not comparable at all. I mean,
It's and so synthetic agents, yeah, I mean, I think the natural agents probably have a lower risk profile, but remember, opioids are natural. Tobacco is natural. These things have addictive potential. And when we use them in ceremony, when we use them in structured ritualistic ways, when we do it in a therapeutic setting, I think the risk is just startlingly low. And this is what the research is showing, whether it's with ketamine. And certainly I've seen people get into relationships with ketamine. It's not without risk.
sure.
So,
Well, I mean, I feel like any psychoactive substance, regardless of what it is, you're going to have some risks. Even if your formal dependence and addiction, like with ketamine, is negligent, it's very low. An actual biologic addiction risk is pretty low. I mean, you especially compared to something like opioids, it's a completely different level of scale here.
well, in Western conventional medicine, for example, deemed that Benadryl, diphenhydramine, was an innocuous agent we could give to babies, we could give to children, and people take it for years as a sleep aid. And now we're realizing that it may be a very significant risk for Alzheimer's and dementia. And people are talking about maybe it needs to be pulled off the market. What is this after 50 or
Well,
80?
not apparently in the current political situation. I just heard through my channels that they're now trying to look for Benadryl as a cure for measles disease in a new government. So hopefully they have smarter people than that. We don't talk politics here, but I couldn't resist myself. But point being, so that's actually a great segue. So, ketamine is the only legal substance that you and I can formally prescribe or recommend in a clinic. Now, you're also in a state that recently legalized psilocybin, and I know your clinic, we just talked about this before we start, that your clinic has been using it and you're also teaching it to providers. But in your mind, does the fact that ketamine is not a Schedule 1 controlled substance, so it can be recommended by providers, does that make ketamine kind of a prime first psychedelic for the whole nation, while the other states are sort of figuring out what they want to do with psilocybin and other psychedelics?
Yeah, I mean, I've actually written a paper on ketamine as a transitional agent between conventional care and psychedelic care for reasons that I can go into, but I do think it is the first way that we can legally, in a way that's sort of medically accepted and understood, begin to play with the flow of information and consciousness that we do in ketamine-assisted psychotherapy to access new information, new memories, new experiences, and create new perspectives and drive insight. And change and insight is all dependent on neuroplasticity, the ability for the brain to change. And that's just another way of saying learning. When people are stuck, they're not learning.
Yeah, that's definitely, our small observation. I mean, of course, our program is much smaller. So you working currently on this whole topic of a burnout. We've just sort of at the tail end of the pandemic that completely reshaped our workforce. We've had tremendous amount of providers burning out, and I mean, I'm at the campus where we had a profound changes in staffing. I think at some point at our university, nearly 30% of clinicians left because of just different scenarios and different everything different. I mean, telemedicine adapting. So tell us what you've seen. I know you guys done several trials, so maybe you can talk a little bit about the papers you published. Of course, if there's anything you want to give us link-wise, we'll include so listeners can also find the descriptions to the podcast and we'll post the links to your articles.
Sure. Well, I've got to first parenthetically, I'll just say that burnout is a massive healthcare issue and was a massive healthcare issue before COVID. I mean, we were looking at burnout rates of 30, 40, sometimes over 50% of frontline healthcare providers. And what they found was these providers were just burned out. They were depressed, they were traumatized, they were fatigued. They had another way of thinking about this is compassion fatigue. They lose the ability to care about those they're caring for because they're so beat up. And I got inspired to do something by my daughter, who at that time was an ICU nurse. She was working in one of the Harvard hospitals during the COVID surge in March, April, May of 2020. And she was caring for 6 and 8 and sometimes 10 patients in an ICU when an ICU nurse should have 2 patients, maybe 3 on a bad day.
Mhm.
And without PPE, they were working in a makeshift waiting room that was converted into an ICU. People were dying without access to their loved ones. And it was just horrific. It was battlefield medicine. And she was traumatized, as many of her colleagues were. And it really inspired me to do something. And I had some understanding of what ketamine could do. And we developed a program over 6 or 7 weeks, a once a week program for 2 or 3 hours a session. And it would alternate between a prep session, a medicine session with ketamine, integration, medicine with ketamine, integration, medicine. So they started out sublingual for the first two, and then IM for the third one. And we would do these in groups of healthcare providers, paramedics, ER docs, ICU nurses, sitting with each other and just going through this process. And it was just immensely rewarding, both for the participants and for our staff who really got to heal the healer and help the helper in a way that was just deeply recharging. And like you said with ketamine, it's quick. These people came out of this 7 week program inspired. Some were inspired to leave their job. Some were inspired to get back into life and start exercising and start playing and, revitalizing their relationships. It just gave people the ability to step back, recharge, and reorient. And we gathered data. We showed very significant responses. We showed effect sizes. I mean, obviously, it's what we call an open label experience. Everyone knows you're getting ketamine. Very hard, actually, in all of psychedelic medicine to blind these things. But it was an open label trial, but we saw effect sizes of like 1.2, 1.5, 1.8 for anxiety, depression, and trauma indicators. And we've duplicated that. We've had a second grant and published two, soon to be three articles on it. And really, what I'm looking for now, as I was telling you earlier, is a healthcare system because the challenge with treating people individually is we're helping them with burnout, but we're not changing their work environment to be more aware, to be more sympathetic, to be more engaged around these issues. And the one thing I've realized in doing this work over the last 4 years is that all of us in medicine carry vicarious trauma, all of us in healthcare. But interestingly enough, so do firefighters, so do policemen. And we're finding that even this issue is prevalent with teachers. They're dealing with burnout, somewhat different reasons, but um, public service is just hard these days. And if we want to keep our communities safe and really top-notch care, we need to care for the healers and realize that we carry this trauma that needs to be processed, that needs to be, and we do this healing in relationship, in community, and working in a group setting like we are, people build community and they build connection and they build rapport and they get a sense that this is a normal process, that I'm not a weak person because I'm crying every day because of all that I've seen. So it's just been very inspiring to me, and I would love to continue this work.
Well, this is the time for you to do it because from what I understand, you recently retired after 40 years uh, as a provider. So now your focus is on research and training and teaching, which is so needed because I know just from listening to Misha talk about medical cannabis and the challenges and the resistance, and not just from uh, policymakers and politicians, but also just from health professionals themselves. And what are some of the challenges that you're facing as you're looking at it from this different position?
Well, thanks, Janet. I've viewed myself really as a change agent or troublemaker, depending on what day it is. And really, what I'm trying to do is think about ways that we can innovate, inspire our healthcare system with novel and interesting approaches that really touch on healing. I'm not interested so much anymore in managing people's misery, but I'm looking for ways that we can empower, that we can inspire. And I'm also looking for models that can be brought into mainstream healthcare. We're moving into the insurance world for the second time in my practice and trying to do it in a thoughtful way where we can improve access. Because one of the downsides of both integrative medicine and psychedelic medicine is that it can be elitist, it can be expensive, it can have narrow access. Um, and I think this is challenging in a variety of ways for disadvantaged populations. And uh, we're trying to create a model that can generalize in a larger healthcare system because I feel like otherwise psychedelic medicine and ketamine will just remain elitist and for the top 5 or 10% that can afford out-of-pocket care for because these are often expensive interventions. So I'm inspired to just keep working to create change and innovate. I love to create and That's what gets me up in the morning.
Is that why you started Prati?
Yeah, I mean, I just love to teach. And in working with ketamine, after 5 years of working with ketamine, I said, this is something that other people would really benefit from doing. And so we created sort of a spiritually based and spiritually centered training program that helps people, professionals, therapists, psychiatrists, psychologists, nurse practitioners, helps them to bring this back where they are because there is just a real deep interest in this. And once you've worked with ketamine for a while, it sort of opens the door to working with psychedelics and seeing sort of the broader application that these things have. You could think of ketamine as a gateway drug going back to the 80s in that way, you know, is that it just opens up people's awareness that there's a different way to work. And I think when we work with the psyche in a deeper way, when we can get past people's defenses and get to really who they are and touch their spirit, people change. And one of the things about working with these agents is once people have had this experience, a deeper connection with spirit, they're often changed in a very enduring way because they see the world in a different way. Um, so that's what inspires me.
I have a couple of practical questions. So you mentioned first, I paid close attention that you did first sublingual. So you did a lozenges and then you did IM. I have usually seen it done the other way, that people will start with more of an injectable and then they will be switched to sublingual. What's your experience here with this?
Um, I think I don't like people to get into rigid protocols at all. Um,
Okay.
when you're doing something like this, you sort of have to, but with our practice, we use four different routes of administration. We do sub-Q, IM, sublingual, and IV. And they each have their place. And because they have an absorption curve that's different, they change the psyche and give access to different types of information.
Hmm.
And so, like, I've been working with people in Australia who have been using subcutaneous as their primary intervention, University of New South Wales and other locations. Colleen Liu, who's a famous researcher there, they had been doing pharmacological ketamine for a decade, but they really didn't understand ketamine-assisted therapy. So I taught them about ketamine-assisted therapy. They taught me about using subcutaneous. And it's been a really rich and rewarding relationship. I still do supervision with them. But the routes of administration are varied. People come with different problems. And one of the key problems I saw in Australia, they were treating people with relatively high dose ketamine for years, and they were still stuck. They would get brief relief, 2, 4 weeks, but these problems just recurred. And so what we would often do is we drop the dose, move to split dosing, um, and just go for what we call a psycholytic experience as opposed to a psychedelic experience.
Hmm.
More is not better. And the people misunderstand that. And people, because IM is so powerful and so impressive, people want to start with that. But people who've been traumatized, people who are anxious, people who are cautious, who are not introspective, that's not a good way to start. And so I really encourage people to think about the kind of path and trajectory you're trying to take someone along
Hmm.
and think about how you work with it. And so sometimes starting low with a sublingual or oral dose and being very gentle makes sense. Occasionally, when people come in who are suicidal, psychotically depressed, we often want IV and we want multiple doses per week.
Hmm.
So I don't think should be a set protocol. I think we need to understand the journey the patient needs to be on.
Hmm. So let's go back to burnout. You talked about different models of delivery. I think one of the big problems with psychedelic assisted therapy is just timing. It's a very low tech, high touch, high time approach. and you're doing groups, right? So you having small groups. Talk to us a little bit about this model, this group model.
I like the group model. We do that particularly with ketamine. We'll probably be stepping into group work with psilocybin, both through PRATI and at Wholeness Center. And group work has a lot of advantages. I'll name a few. Number one, it's cheaper because if you get 6 people in a group with one or two providers, it's half, a third the cost. And you're right, these are long treatments. A psilocybin session is 6, 8 hours, an MDMA session is 5 or 6 or 7 hours, and ketamine 2 hours, maybe 3 hours. So the manpower, the woman power, the staffing issue is really what drives the cost because these, by and large, are not expensive agents. So it's time. But groups also build community, they build rapport. Um, these agents, ketamine included, have a way of decreasing our defenses and opening us to connection with others. And it really just accelerates the process of connecting with others. And one of the definitions of psychiatric illness, whether it's addiction or depression, is isolation. And what we're doing is trying to build relationships because when people feel connected, they feel solace, they feel heard, and they suffer less. And so I think groups also normalize this process of I'm dealing with an issue, I'm having some pain and distress, I need some help. And when we see others dealing with that, we say, okay, I'm not a bad person. I'm just I'm just looking for something that I need. So I think groups are the future, honestly, of psychedelic medicine.
Yeah, we just got a small grant to repeat our group ketamine for long COVID. I mean, we've seen some interesting things in the first group we did, and now just we got a small grant to repeat this. So I think we've starting to kind of see that what you're describing being quite powerful since we have such a large long COVID community at our clinic. So you taking conditions and you group the retreats or you group the experiences based on a specific condition, right? They're not necessarily um, and so you're doing this for a variety of, do you do something that other than mental health right now in your clinic, or are you guys mostly mental health based?
Yeah, it's predominantly mental health based. I think we've had some thought and discussion about broadening out, maybe to include chronic pain.
Hmm.
We're just recruiting now a PA who's running an integrative pain program in the Twin Cities. And that's intriguing because we've got all the tools to deal with chronic pain, and it's a difficult population that really struggles. Often practitioners don't want to deal with them, and they sort of get marginalized and often don't get the highest quality of care. So we're exploring that, but yes, traditionally we've been a mental health clinic.
I think before we wrap up, since time we don't have a lot of time left, but I wanted to ask you, so I love how you have a nonprofit that tries to do this. We have nonprofit here, AIM Health Institute, and this is very close to my heart, saying, look, this substances are by all in all, compared to at least other medications we're using, are really inexpensive, and they should be available to everybody instead of elitist. Um, so, what do you tell to not just politicians and policymakers, but also just to the leaders of different organizations, those who are still skeptical and thinking, oh, our Medicaid population should not have access to the substances and, they're dangerous. And I think there's still some stigma, but yet this is the population that is often, impacted heavily by mental health and also chronic pain. And ketamine specifically can be a part of an answer to all of this. What do you tell them? How do you advocate for those who really don't have capacity to buy this or, go to the expensive clinics?
And that's why I think we need to build a model that has insurance access as a part of it. I think we also need to convince the community mental health centers, state hospitals, the sort of the whole mental health care network, safety net, that psilocybin shows durable positive change with one or two treatments. And for the population that they're dealing with, where they're basically almost instituting a lifelong policy of management,
Hmm.
where people are managed in a way that maybe offers them comfort, but doesn't offer them cure. And I think if we can show people that psilocybin, for example, and perhaps ketamine, offers people some true opportunity for change and at least approaching significant durable improvement, that's a new paradigm of care. And I think that is going to, at some point, we're going to have the economic data to show them that it's just silly to continue doing it the way we're doing it.
Yeah, I can't agree more. I mean, I think there's such a profound need. We've been trying to talk to the DC Medicaid regarding chronic pain, and we even had some of the senior leaders in DC Medicaid do sort of tell us that ketamine is on consideration, but I think there is still quite a good amount of resistance, and in my mind, unfortunately, it's not warranted. And then, of course, we also hear all the time about Spravato, which both you and I know it's not as good as doing other forms of ketamine, and also Spravato is not a cost-saving solution. It's extremely expensive as a patent drug. So, I don't know where I'm going with this, but point being is I think it's important that we acknowledge that we have to keep pushing for the access here. Yeah.
Oh, I think that's our big struggle. And it's a big struggle of just documenting effectiveness, documenting safety. I really think that when MDMA is approved, it's going to change mental health care as we know it because so much in our chronic populations is trauma based. There's such an enormous trauma load in our society, and we tend to ignore it, and to our great disadvantage. So I think these agents offer potential promise, and it's not without peril, but I think there is an opportunity to embrace this new paradigm, which I think ketamine reflects so well.
I think we'll bring you back for the MDMA. I think all of us were completely bummed out when, FDA did not approve it last summer, but hopefully they'll come around and hopefully we will meet with you to talk about it because of course those of our listeners who don't know, MDMA is probably one of the most profound trauma supportive treatments we have at the moment. But let's finish up with the what's next for you guys? Where are you going? I mean, I know the trainings, research, any new directions of research?
Well, we just launched our healing center at Wholeness in Fort Collins, and we're now licensed to provide psilocybin care. And so I think we're going to bring in, we've been doing QEEGs, brain maps, and really trying to integrate this with psilocybin, with ketamine, with the integrative tools we use, and really seeing what's the next frontier. And maybe we're going to be adding in TMS as well, and trying to just have this whole sort of neuromodulation mindset that we've got a brain, it's plastic, and we should make use of that and see how people can grow and change. And that's what still calls to me.
Such a great place to end. Scott, thank you so much for coming. It's such a joy to have you here, and I swear we're gonna have to have you back. Just no discussions. You're gonna have to give us another hour sometime later.
Well, twist my arm. I enjoy talking to you. It's always nice to connect, Misha. It's been such a pleasure to be on this ride with you over the last few decades.
Thank you. Thank you.
Thank you, Janet.
Thank you, Scott. Well, friends, this is the GW Integrative Medicine podcast from the GW Office of Integrative Medicine and Health.
I'm Dr. Misha Kogan.
And I'm Janet Rodriguez. So thanks for
Thanks for
listening.
listening.